University of Toronto Joint Center for Bioethics Seminar Series. I'm Angel Petropanagos, and I'll be the moderator for today's session. Our speaker today is Alison Thompson, and her seminar is entitled COVID-19 Vaccine Ethics, Creating a Climate of Trust. Before I introduce today's speaker, I'd like to let you know that the seminar is being recorded, and this lecture, along with other archived lectures, can be accessed through the Joint Center for Bioethics website. The format of our seminar is a presentation by our speaker, followed by a facilitated discussion period. We'd like to take a moment to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. We also stand in solidarity with the ongoing protests against racism and systemic discrimination. Now, it is my pleasure to introduce you to today's speaker. Alison Thompson is an associate professor at the Leslie Dan Faculty of Pharmacy, Dalla Lana School of Public Health, and a member of the University of Toronto Joint Center for Bioethics. She is a fellow in the WHO Collaborating Center for Governance, Transparency, and Accountability in the pharmaceutical sector, and is currently a visiting fellow at the Center for Advanced Studies, Ludwig Maximilian University of Munich. Welcome, Alison. Over to you.
Before I begin, I just want to start my talk today. Thank you, Angel, for the introduction. And thank you for your interest in discussing with me today the topic of COVID-19 vaccines and trust. Before I begin, I just want to acknowledge the contribution of Professor Emerita Ann Robertson of the Dalla Lana School of Public Health and Dr. Sarah Kim, whose work with me on this topic during the H1N1 pandemic in 2009 informed my thinking on vaccine ethics, and some of their thoughts are reflected in this talk today. I want to start my talk today with the news ripped from the headlines that the UK has approved the Pfizer-BioNTech vaccine ahead of every other nation in the world. The Guardian has talked about how it won the race to do this ahead of the EU and the United States. And for some people, this is going to be good news, and for others, it's going to cause them to worry. It's worrying not just because the US has lost the race to put America first again when it comes to vaccine approvals, and because Stephen Hahn is probably going to be fired by Trump because of this. It's worrying because pitting countries against each other in a race to get the vaccine into people first undermines trust in vaccines, and it leaves millions of countries entitled to life-saving resources like vaccines dependent on their nation's ability to pay for access to vaccines. So we can see that ethical issues abound when it comes to COVID-19 vaccines. So some questions we can answer.
Apologies, everyone, for the technical difficulty. Angel, do you happen to have it on your computer?
I do. Give me a second. I'll pull it up, and I will stream it from here.
Apologies.
Thanks for your patience, everyone. I'm just working on getting it open. There's a bit of trouble with the document, but it should be up in a few seconds.
Hi, everyone. Thanks for your patience. We should be back in a minute or two. Thank you.
Before I begin, I just want to acknowledge the contribution of Professor Emerita Ann Robertson of the Dalla Lana School of Public Health and Dr. Sarah Kim, whose work with me on this topic during the H1N1 pandemic in 2009 informed my thinking on vaccine ethics, and some of their thoughts are reflected in this talk today. I want to start my talk today with the news ripped from the headlines that the UK has approved the Pfizer BioNTech vaccine ahead of every other nation in the world. The Guardian has talked about how it won the race to do this ahead of the EU and the United States. And for some people, this is going to be good news, and for others, it's going to cause them to worry. It's worrying not just because the US has lost the race to put America first again when it comes to vaccine approvals, and because Stephen Hahn is probably going to be fired by Trump because of this. It's worrying because pitting countries against each other in a race to get the vaccine into people first undermines trust in vaccines, and it leaves millions of countries entitled to life-saving resources like vaccines dependent on their nation's ability to pay for access to vaccines. So we can see that ethical issues abound when it comes to COVID-19 vaccines. So some questions we can answer by turning to science. when it comes to vaccination for COVID-19. But there are also ethical questions that science can't answer because they involve weighing and prioritizing public values, personal values, and principles. So some of these questions that we can apply ethics to is, what does a fair distribution of vaccines look like in Canada? What does it look like globally? Who should get priority access to vaccines? Can we compel people to get vaccinated? Can we limit individual rights and freedoms for those who are unimmunized and implement things like immunity passports? For me, the most important ethical issue when it comes to vaccination for COVID-19 is trust. Many of the ethical decisions around COVID-19 have the potential to undermine or foster trust between groups. And when it comes to vaccines, there are actual or potential trust cleavages between many different groups in society. There's a trust cleavage between many members of the public and the pharmaceutical industry, the public and the regulators in charge of approving vaccines, like Health Canada, the public and public health. We've seen lots of demonstrations in recent days about anti-masking, anti-quarantine, anti-lockdown, and this picture here is from an anti-vaccine rally where you can see Dr. Fauci is being lumped in with Big Pharma. And publics and hospitals and clinics, there are trust cleavages there, particularly for Black and Indigenous communities. There are trust cleavages between the public and healthcare providers, vaxxers and anti-vaxxers, providers and patients, and government, public health, and industry. So there are many places where we need trust to function and where it can potentially break down. We need to get this right. Public health can't function without the public's trust. We rely on it to make sure that people are complying with public health measures, to make sure that they can get vaccinated, to make sure that the most vulnerable people in society are protected. So if we fail to anticipate and address issues around trust, this could really have disastrous consequences, not just for this particular pandemic, but for the future of immunization programs around the world. And this is a point that Heidi Larson from the Vaccine Confidence Project at the London School of Hygiene and Tropical Medicine has made, that the stakes are high here. We might see an increase in vaccine hesitancy. We can see an increase in global inequities in health. And we also might see an increasing mistrust in scientific institutions, in industry, in governments, and public health. One of the big issues that we will be facing is the issue of vaccine hesitancy. The WHO has vaccine hesitancy on its list of the top 10 threats to global health in 2019, and I suspect it'll be there again in 2020. Often, when we talk about vaccine hesitancy, people emphasize the importance of communication. And the importance of accurate scientific information to combat what has been called the infodemic. And as you can see here, this infodemic has been really to the fore in many conversations about COVID-19 and public health communication. Trust is identified in the WHO Outbreak Communication Planning Guide that I helped to work on in 2008 as being of primary importance. So without trust, people are not going to roll up their sleeves for a vaccine. They're not going to stay home when we ask them to. They're not going to quarantine. They're not going to wear a mask. So we know that the misinformation that people find on the internet is problematic, for sure. But even if we could deal with that, it's not going to solve the problem alone. And this is a finding from Heidi Larson's research, again, from the London School of Hygiene and Tropical Medicine. And that is because we know that how people take up scientific information is not just a matter of their scientific literacy. It's about who is communicating it, and whether they are trusted. So communication is about more than just providing the right facts about vaccination, for example. And the public will take up information from sources they trust. And that means we have a question to ask ourselves about how do we make public health, government, and scientists more trustworthy. So we need to talk about the relationship between vaccine hesitancy and trust. There are some great examples from recent history of where trust cleavages have caused serious vaccine hesitancy issues. This is an example from Pakistan where the quote from the article from the New York Times says that the fact that the CIA used a vaccination team to track down Osama bin Laden in Pakistan in 2011 has helped fuel the resistance to vaccination campaigns in the country. And this has set back the eradicate polio movement globally because there is no longer trust in the healthcare workers who are trying to immunize people in Pakistan. Similarly, in Nigeria, there's also a problem with trustworthiness around the polio vaccine. We know from social science literature that vaccine hesitancy is related to mistrust. There a meta-review that was in Social Science and Medicine. Sorry, you can't see that very well in this picture, but it cites that reasons that relate to issues of mistrust are cited much more commonly in the literature than reasons that are related to an information deficit. So that deficit model of the public understanding of science, where the public is viewed as an empty vessel to be filled up with the right facts, is not really accurate, and we need to be much more nuanced in how we think about providing information to people, who is providing it, and whether or not they are trustworthy to the public. A recent Nature Medicine global survey that was published in October talked about the fact that respondents who said that they trusted their government were more likely to accept a vaccine than those who said that they did not. And there was a direct correlation between countries where trust in government is low and anti-vaccine sentiment. And even though these kinds of studies are not necessarily going to be that accurate, because studies that ask people about their intention to get vaccinated are not always that great at predicting whether or not they will, particularly if it's a pandemic situation and the perceived risk from the disease is high, like it is with COVID-19, then we know that can have an effect too on whether or not people will actually be vaccinated. So what are we talking about when we're talking about trust? We kind of intuitively know what we're talking about, but what does a philosophical perspective on this tell us, and why is this useful? People talk about vaccine confidence. You see that from the Vaccine Confidence Project. Is it the same thing as trust? Let's look at this. So how should we think about trust? There's lots of research from lots of different disciplines on trust, about how the public decides to place their trust, about how much they trust, can we measure that, and when they trust. And these kinds of studies aim to quantify and describe and measure trust in the context of infectious disease outbreaks. And this is all based on this underlying premise that it's possible to create the conditions under which public trust can be fostered or reinforced or maintained. A philosophical understanding of trust is a little bit different. We're not so interested in measuring and quantifying as we are in really understanding what we're talking about when we're talking about trust. Personally, I like Russell Hardin's notion that trust is a capacity that is shaped by people's experience. So trust in interpersonal relationships between you and your coworker, between your patient and your provider, is much easier to place than it is to place trust in an institution or a government or system, like a regulatory system. And that's because those thick relationships that we can have between individuals are not possible when we're talking about an institution. And as Pink Floyd famously asked at the Berlin Wall when they did their concert there before it fell, "Mother, should I trust the government?" So these are tough questions. How do people learn to trust governments when we don't have those thick relationships that are based on, looking at each other, on relationships that are much more personal? Trusting creates risk and vulnerability for the person who is placing their trust. It's inherent in all trust relations, and it speaks to a power differential. If you are needing to trust someone, then they have power over you. And it comes with uncertainty, and it also comes with expectations that someone will behave in a trustworthy manner. It involves a calculation of a probability that the person or the institution that you are trusting will act in your interests. And that is where people's past experience comes into play, because their calculation of probability is going to be very much informed by their past experiences. But vulnerability that's created through the trusting relationship creates an interdependence between the truster and the trustee. And there has to be a reliance and a reciprocity there between those people with the power, the trustees, and those with vulnerability to decisions around vaccination, so the trusters. This idea that trust requires reciprocity is interesting, and I think that's why I would be hesitant to say that confidence is an interchangeable word with trust. So the Vaccine Confidence Project means something different to me than the Vaccine Trust Project, because we don't really have a counterpart to having confidence in something that gets at this relationship of reciprocity. So what I mean by that is that trust binds us all in a sort of commons that is required for social progress. So we can't really have institutions that function well, public health that can operate well without that sort of commons of trust that is necessary. And the responsibility of being trusted carries a social value. When we trust, we create a normative pressure on the person who's entrusted, which acts as a kind of a regulatory and moral mechanism that's inherent in the trust exchange. And when that's not possible, when that normative pressure is not as clear, so for example, when we don't really know what the normative pressure we are exerting on an institution might be, there are also mechanisms that we can put into place that provide institutional enforcement of trust or legal pressure as opposed to moral pressure on the entrusted. So an example of that from the economics literature would be a contract. So when I buy a house, I typically will sign a contract because I may not know the person that I'm buying the house from, and vice versa. So that relationship of trust can be bolstered by these sort of legal mechanisms or other institutional mechanisms of enforcement. So the entrusted also stands to lose something in a failed trust exchange. Again, if you think about the economics of that kind of a situation, if a company fails to honor contracts, they are going to suffer. So the act of trusting lends itself to creating trustworthiness and mutual cooperation, or solidarity in this case. So when it comes to public trust and COVID-19, what are we talking about? Those who are most burdened by COVID-19 from a disease perspective and from social hardship perspective have historically had low trust in the health system and government. So breaches in the social contract for many racialized and other disadvantaged communities, like the disability community, or persons living with disabilities, leads to low trust in governments and health institutions. So examples of this is the sort of structural racism that we are seeing being talked about a lot during COVID-19. And there are even examples of ethnic tensions within and between countries that can lead to problems around vaccine hesitancy. One example is in Ethiopia, where the dominant group wanted to provide the HPV vaccine to a minority group, and there were ethnic tensions between those groups, and it was perceived as a means of sterilizing that population. And so mistrust can be rooted in these sort of ethnic tensions or structural racism in societies and other forms of discrimination. There's sexism, ableism, all kinds of these sort of social structural means of discriminating against people. There's also stigmatization that we need to think about that can create mistrust. You know, if we target a particular group for immunization with a vaccine aimed at reducing sexually transmitted infection, for example, is that stigmatizing? These groups also have difficulty accessing care, and there is a disproportionate burden from the disease itself, but also in the medical research that is done on people to develop vaccines. And so here we have an example of an article from Al Jazeera that came out recently about the medical colonialism in Africa when it comes to medical research and the burden that Africans have borne on researching new drugs. From May 2008, we see in The Lancet, there was a news piece about the mounting evidence that there is a disproportionate effect of COVID-19 on ethnic minorities. And that is highly relevant to this conversation because this is not new. We've seen protests in Africa about vaccine tests, which illustrate the mistrust there between Africans who are being asked to participate in clinical trials for vaccines. And this is important because these are also the groups who are most likely to be prioritized for access to COVID-19 vaccines. You can see here that the WHO advisory group values framework for the allocation and prioritization of COVID-19 vaccines has prioritized global equity and national equity, which means that there needs to be greater access or prioritization for groups experiencing greater burdens from COVID-19 disease and social consequences. But we need to think about how that is going to be interpreted by those groups if you take into consideration the fact that there's low trust. When we prioritize them, will they view this as a good thing, or will they see this as another example of them being prioritized with the aim of using them as guinea pigs for a new novel vaccine, where they will bear the burdens of any safety or effectiveness issues that might emerge from those new vaccines? So going back to how people place their trust again, when there is a baseline skepticism, if not a blatant mistrust, that's been learned from past experiences and informs one initial assessments, as Russell Harden would say, one cannot simply start trusting people tomorrow unless the people one deals with are suddenly different in relevant ways. And so the best device for creating trust is to establish and support trustworthiness. So let's switch this focus that we've had from looking at how the public places their trust, how to measure it, and let's look really closely at how do we move from talking about trust to trustworthiness. Well, when we recall that we talked about how when you place your trust, you are creating a vulnerability and there is some risk involved. So what are some of those things that have happened in COVID that have increased people's vulnerability and risk in trusting a COVID-19 vaccine? Well, first of all, there's been a pretty spectacular failure on the part of many countries to view vaccines as global public goods, even though they may say they do, and they've contributed to the COVAX efforts to have a fair distribution of and development of vaccines globally, people are still treating vaccines as commodities to be bought and sold on the market, and ability to pay seems to be the thing that's going to determine who gets them first, regardless of who needs them the most. There is a real lack of industry accountability to share to the public, even though many of these vaccines have millions of dollars of public funding in them. There's been a complete failure to be transparent. There has been stock sell-offs after large vaccine announcements, like we saw with Moderna and Pfizer, that really undermine public trust. There's a lack of transparency around national procurement and pricing strategies. Trudeau's government has failed to be transparent about what they paid for access to vaccines that are coming online soon. There's a lack of transparency in the clinical trial data. We saw a lot of science by press release a couple of weeks ago when Pfizer and Moderna released these efficacy rates for their vaccine trials without releasing more data, which were closely followed by these prearranged stock sell-offs. So there's a lot of questionable behavior going on there. There's a lack of capacity for surveillance and monitoring and reporting of adverse events following immunization in Canada. We have a paltry patchwork kind of system that really needs to be ramped up. And we also need to be linking it with the global community. There's a lack of vaccine injury compensation schemes in Canada. There's only Quebec that has a compensation scheme for injuries from vaccines. And we saw recently in the US that they have stopped funding their vaccine injury compensation schemes from industry money, and now it will be coming out of taxpayers' pockets. So that all of these things, coupled with these inequities in the burden of research and access and distribution and prioritization of vaccines, really creates a vulnerability for the public when they are thinking about getting vaccinated and trusting that they are going to be safe and effective. So when these sort of thick relationships are not possible, it makes placing trust more difficult. I think we need to be looking at creating these mechanisms that can provide institutional enforcement of trustworthiness, because we just don't have those thick relationships with government, with public health, and with Health Canada. So what builds trustworthiness or creates what Bayer has called a climate of trust around vaccines? Well, I think we can do some things to address the vulnerabilities and the risks that I just outlined. So first of all, we need to be looking at how to reduce the vulnerability and risk that stems from trusting by using the best evidence possible in the circumstances. We need access to those clinical trial data. We need to have appeal mechanisms for people who feel that they have legitimate claims to prioritized access for vaccines. We need to talk about what will happen if priority groups don't want to be prioritized. We need to be monitoring for these adverse events following immunization systematically, and we need to be proactively reacting to any kind of safety concerns that might emerge or concerns around a lack of effectiveness of a vaccine. And we need to be doing that as a global community. This is one area where we might suggest that Canada is not going to be that badly off for not being first in line for access to some of these vaccines. We need a precautionary regulatory response to these safety signals. So we know that when these signals pop up, we know that we need to be responding proactively and balancing the risk of withholding vaccines from the public because of safety signals from and balancing that with the need for that sort of herd immunity in the population from COVID-19. And lastly, we need some vaccine injury compensation schemes, which will be funded by industry or possibly the government if they renege on the trust placed in them to provide safe and effective vaccines. Second of all, I think we need to help people facilitate the wise placement of their trust. And that requires transparency around vaccine development by releasing clinical trial data, by improving transparency around how decisions will be taken about licensure for these vaccines. Procurement, obviously, there's been quite a lot of talk about why the Canadian government hasn't been transparent about what they paid. As I mentioned earlier, transparency about how they will be distributed, administered, and all of this adverse event monitoring and reporting. We need some transparency around the conflicts of interest that are at play in vaccine development, and how decisions for procurement, distribution, and prioritized access are being made. And lastly, we need to be communicating and consulting to improve the legitimacy of vaccine-related decisions. We need to be listening to people's concerns, and then we need to listen, and then we need to listen some more. Communication is a two-way street. It's not just about providing people with information. It's about listening and responding to their concerns around vaccines. And there's no monolithic voice here. There are many different publics with many different kinds of concerns, some of them historically based, some of them religiously based, and some of them are brand new concerns around the sort of politicization of this vaccine and how it's been regulated and developed. We need to encourage people to have face-to-face interactions where possible to develop those thick relations. And so here's a place where healthcare providers can really step in to help people address their concerns about vaccines and to provide information for them. And I think there needs to be more engagement with these publics, especially for the most vulnerable groups who are likely to be prioritized for vaccines through robust mechanisms that we need to create before, during, and after vaccination. So just to sum up then, there are moral and pragmatic reasons to be trustworthy. Pharmaceutical companies have an interest in being trustworthy or they won't sell many products. And public health and government have an interest in being trustworthy or the public won't comply with measures like vaccination, masking, quarantine, etc. I want to thank everybody for your attention today, and I am happy to take your questions. Thank you.
Alison, thank you. Thank you for that presentation. So we're now going to turn to the discussion period of our seminar. And there are a couple ways that you can ask questions. So if you are watching from YouTube, you can type into the YouTube chat. If you prefer, you can also send an email to Lori Bulchak at utoronto.ca. I think her email is probably somewhere in the chat on YouTube there. And questions sent through email can be anonymous as well. Okay, and Alison, are you there? Just make sure, yes, okay. I know we're having some technical difficulties earlier, so just want to make sure that you can hear us okay and everything is working, all right? Okay. So I'm gonna pull up our questions here. Okay, so we've got a few. All right, so we have a question from Shelley. She asks, what independent contracts exist for vaccines, especially when the government continues to legislate immunity for legal suit, as they have done for the long-term care sector?
Thank you for your question. I'm not quite sure I understand the question. Certainly, there are issues around mandatory vaccination, if that's what you're referring to there, which are really, really tricky, especially when it comes to mandatory vaccination of healthcare workers, which we know has been a sort of issue that's a hot button issue in the past, especially around the influenza vaccine. And it too has raised many issues around trust within healthcare institutions, and it tends to be the people who have been sort of treated badly or lower on the hierarchy in the hospital. If you think of doctors being at the top and then sort of paraprofessionals lower down, we certainly see more resistance to those sort of mandatory vaccination policies in those sort of more less powerful groups in hospitals too. So I think that, while there may be compelling ethical reasons to mandate that healthcare workers are immunized, it's a difficult argument to make when you have a brand new vaccine. Usually when we're talking about mandatory vaccination, we would only do that when we have really hard evidence over a long period of time that a vaccine is safe and effective. And so I think that if we are looking at mandating vaccination for COVID-19, it will not be in this sort of near term. I think it would be a situation we would get into when we know much more about the vaccines and how safe and effective they are, and whether they are even effective at preventing transmission, which we still don't know.
Thanks, Alison. I see we have a clarification as well from Shelley.
Oh,
she
great.
said,
Okay.
they said, sorry, to clarify, if the government agrees to cover any damages from the taking of vaccines, that would encourage trust and be reciprocal, as it is a house contract or similar to a house contract.
Right. So yeah, so this is another issue. Everything about vaccination is controversial, it seems, but there is a lot of debate over whether providing some kind of compensation for vaccine injury undermines trust. And I think certainly, having looked at this issue from this perspective, where we're talking about making it easier to trust, people are not going to trust if we don't acknowledge that vaccines carry some risk. And, that's not something that public health likes to talk about. They are not completely risk-free. They are most of the time far safer and more effective than medicines are, because the risk-benefit ratio needs to be much different because we're giving them to healthy people. But that doesn't mean that they are 100% safe and that we can always know who is most likely to suffer an adverse reaction. And so I think by acknowledging that, and by acknowledging the fact that these injuries do take place and that, you can be compensated for that through some kind of formal mechanism, either funded by a sort of levy on industry or from the government, I think that it intuitively makes it easier to trust. And it's much more honest about the fact that these are not completely risk-free propositions.
Okay, thank you. Our next question is from Joshua. They ask, so evidence mounts on the disproportionate effect of COVID-19 on ethnic minorities. Is this also the case when the population, the vaccines are being tested on?
So that's a great question, and it depends on what vaccine we're talking about here. I think most of the vaccines that we've been talking about in Canada recently, the Pfizer one, the AstraZeneca one, and the Moderna one, and most recently the Johnson & Johnson one, I think there's been an effort to include groups that are traditionally excluded from clinical trials. So much more diversity, but that doesn't mean that they are going to be able to say with a ton of confidence that those differences are not going to be relevant to the safety or effectiveness of a vaccine. Where I think there has been a lot of research done in India and China where there's a much less transparency about who's been included in those trials and around the data from those trials. And so I think that it'll be interesting to see at the end of the day, who bore the burden of this research, and who paid for it. There's a lot of public money in these vaccines, and there's also a lot of profit to be made. So I think it's maybe a little bit early to tell, and I think even though there are global efforts to make sure that these things are done fairly and equitably, when you've got countries who are nationalistic in their approach, like the US, it's much more difficult to mandate these kinds of things being part of trials.
Thank you. Shelley asks, how do you build trust when the speed of approval of vaccines and monitoring of possible adverse consequences is so much shorter than typical for approval of vaccines for a new coronavirus?
So here's where I think we need to know a lot more from these manufacturers and producers of vaccines about what they've done. And I think everyone has said, yeah, we've compressed the timeline, but we really know what that means. So I see my internet's a little bit slow. I'm hoping you can still hear me.
I think we're still okay.
Okay, good. So, I think people's concerns around being first in line are probably, justifiable here. I've heard a lot of people say, well, I want the vaccine, but I don't want to be first in line, so there is this sense that we have compressed the timeline and somehow compromised safety. And whether or not that's the case, we need to be doing a better job of communicating, what the safety standards are, that the regulatory process, even though that too has been sped up, has not lessened its standards for licensing these vaccines. So, there's many points along the way where the safety and effectiveness of these vaccines can be checked. And, we would hope that Health Canada would be looking at that much more carefully. And, the fact that the UK has now licensed one, and the US is now scrambling to do that, heads will roll because they didn't get there first, that Operation Warp Speed stuff, like they obviously didn't watch Star Trek and see how many times the warp drive broke down, so the idea that we need to be a little bit more cautious is not lost on people. And I think we need to be really clear about what the safety standards are for vaccines, because I'm not sure that people know that very well.
Thanks. So we have a question from Dr. Paula Michelli, and excuse the pronunciation if that wasn't right. My apologies. So they ask, we encourage people to have face-to-face interactions with their doctors, but if the doctors are not being compensated for these interactions, then there could be a problem. How can this be addressed?
So, so this is a great question. I think, a lot of physicians do see it as part of their job to provide the information that people need to make an informed decision about drugs and vaccines. And, for a patient who may have concerns that, they want to have a longer conversation, maybe we need to be looking at mechanisms to allow that to happen. We know that time is the greatest constraint on providing quality patient care. So, how can we facilitate these conversations more effectively? Is it really in our best interests to be just showing them a video when they are refusing to get vaccinated and then making them sign something saying that they've been educated, but they still refuse? These are questionable practices. So I think that's a great question. And beyond that sort of personal relationship with physicians, I think public health can also be doing a much better job at creating those thick relations, and rather than just trying to shut down conversations around vaccine hesitancy.
Okay, thank you. So we have a related question from TechMedic NJ. So they say, several of my fellow healthcare providers have expressed distrust in the vaccine and don't plan on accepting it unless it's mandated. Any advice on peer-to-peer discussions about it?
That's a great question too. I mean, I think a group of us did a study about what happened after some hospitals in Toronto mandated the flu vaccine, or you would have to wear a mask for healthcare providers. And I would say overall that the morale and the mistrust that policy created was not insubstantial. So whether or not it was effective in reducing the transmission of influenza, it certainly decreased trust in hospital management. So, and one of the things that was really interesting about those interviews was that there was a lot of reports of abuse from colleagues for people who didn't want to get vaccinated or couldn't get vaccinated, and the violation of their privacy around having to wear a mask because it became public whether or not you were vaccinated because you were masking. And so I think that these are issues that are difficult to address at that interpersonal level with a colleague. But once again, I think listening is the first step here. What are people's concerns? And what's at the root of them? Because often I think it's not that they don't have the right information. It's that there's a real problem with that basic trust in the institution or big pharma or whatever it is. So, whatever you can do to listen to those concerns and perhaps, address them if you can, refer them to someone who can, that may be one way to deal with that.
Thank you. So our next question, they ask, so the trust that people put in the people giving the vaccines, i.e. nurses, needs to be firmly placed. And those people need to be trained to understand people's concerns and what the research tells us. I've had a nurse tell me flat out that the adverse effects or events from vaccines are all fake, that no one has ever had serious side effects from a vaccine. How would you suggest nurses get the proper education? And should we work on improving nursing empirical perspectives on vaccination?
Thank you for that. I've heard similar stories from people who are convinced that they've had adverse reactions to vaccines only to be told that it's all in their head, or that there's no possible way that was a causal relationship. And while that might be true in many cases, I think that the sort of rule about outbreak management 101 is let's be completely frank here about what we know and what we don't know. And I think we know that establishing the causation of a vaccine injury is one of the most difficult things to prove, right? It's a very tricky thing. But if you are going to invalidate somebody's sort of lived experience of what they think is a vaccine injury, you're breaking their trust. You are not listening. There's a sort of testimonial injustice there that may be at work depending on who is talking. And so, certainly I don't think nurses are the only people where this happens. So, just I think starting from the place where, each individual in front of you is not the population, and all of this data is about population level effects. Listen to that person, and it really starts with basic communication training, I think, for people providing immunizations.
Thanks. So we have another question, interesting suggestion. So they say they've worked in pharma for 4 years and there were always early adopters and late adopters for novel medicines. Is there any value in differentiating between late adopters versus vaccine hesitancy?
That's a great question. I think that certainly, vaccine hesitancy is a problematic term. It's lumping a whole bunch of concerns together under one label, and it implies that there's a certainty that can be provided. We can eradicate that hesitancy with perhaps information or a more trusting relationship or whatever it is. I'm not sure that's always the case. And, certainly I think a lot of the research has shown that a lot of people are hesitant because they want to wait and see.
or because it's not convenient. So, the reason for late adoption could also be varied as well. So I think that's an interesting way to look at it, and certainly late adopters are not vaccine refusal people who refuse vaccines, and so we need to make a distinction there.
So I see that we have a couple more questions, a few more, and we're getting close to 5 o'clock. Are you okay, Alison, if we go a couple minutes over? Okay, we'll try to get all these questions in. Great. So our next question, they say a lot of the trust issues presented seem to require the larger government and or global leaders to discuss and figure out, which is beyond the scope of a local public health unit. So what can local public health units do within their scope that can support the building of trust for COVID vaccines?
I like this question because I think this is where building trust starts, is at that community level. And I think, I'm going to say it again, I think the most important thing that public health can do is not shut down conversations about concerns around vaccination. And I've seen this time and again where people's concerns are dismissed as irrational or a product of skewed risk perception or just plain, conspiracy theories, whatever it is. Regardless of what people's concerns are, you have to meet them where they are, and you have to be willing to listen to them. And I think listening is the key here. And in trying to engage in a conversation, you're not going to convince everybody, but I think the fact that people are not listened to, they are constantly dismissed, even shamed and derided for having concerns about vaccines is really problematic. And I think at that community level, that's where you can have those conversations and establish those relationships in a really much more thick way than you can with a bigger institution.
So our next question is, where is the Health Canada approval process with respect to the vaccines we have purchased?
That's a great question, and I don't know exactly where we're at. I think that what tends to happen with these things is Health Canada, because they often don't have the resources, they tend to rely on data from other jurisdictions. But I think in this case, they are going to be looking very carefully at these data. Part of it will depend on how transparent the industry is with their clinical trial data, but certainly they will be wanting to get this done yesterday so that we can get these vaccines out to people. And so, I think you could probably do a Google search and find out. Maybe Health Canada's website has some information there. But if you can't find out that information, that's a problem. And I think that speaks to the need for more transparency from the regulator here.
And our last question. So doctors often seek out patient decision-making tools to support patient agency. However, in measles outbreak, so they're thinking back to 2018, 2019, there were no tools available for distribution. So they ask, what can we do to get these proactively for COVID?
That's a great question. I wonder whether, I do wonder about those tools and how well they work, whether they're more for the physician or the nurse than they are for the patient. And so thinking through this from the patient perspective, and proactively trying to address concerns that are coming from your patients and doing that sort of the other way around might be an interesting way to do that, and to develop a tool that's much more sort of coming from the patient's perspective would also be an interesting thing to do. And certainly there's lots of people in Canada doing research on this vaccine hesitancy issue and intention to vaccinate with the COVID vaccine. So that could inform those tools.
Really great information. Thank you, Alison. So it's time now to draw today's seminar to a close. So I do have a couple of announcements to make before we thank our speaker. Our next seminar will be in the new year, so 2021. It'll be on Wednesday, January 13th. Ahmed Al-Awamir will be discussing how did medical assistance in dying impact palliative care. And to sign up to receive our weekly seminar reminders via email, please send an email to jcb.info@utoronto.ca. For those participants watching today who are CSB students enrolled in the CSB Student Seminar course, please remember to keep track of your attendance. And finally, but not least, Alison, on behalf of all of us, thank you very much for your presentation today.
Thank you to everybody for tuning in. It was a pleasure.